So the first talk today is on outcomes of ventral hernia repair in the non-obese and the obese. Mohamed Dahman. Thank you, Dr. Dahman.
So Green will advance, Red goes back. The mic is live, you'll have 5 minutes with 1 minute wrap up.
Okay. Good evening, everyone. Dr. Edelman, Dr. Finelli, thank you for having us to share our data with you here. Today I'm going to be discussing our outcomes of ventral hernia repair in the non-obese and the obese. This is my disclosure. So I think this is every surgeon's nightmare. What are we going to do with this patient? We deal with a lot of obese patients and super obese patients. And I think this is a category of patients that a lot of surgeons shy away from, offering them surgical intervention. And I think, we should study more outcomes in this patient population and certainly offer them the best of care we can. So background on our research. Obesity, as everyone knows, is an epidemic worldwide, as well as in the US. Overweight and obesity affects at least 1.7 billion. Since 1978, and just in 30 years, obese Americans have risen from 14% to 33%. I think a lot of people, a lot of the audience here have seen this map. It's a map of the US, and it's the BRFSS. It's a survey that has been conducted by the CDC. And I think it's actually an underestimated results because it represents here in 1985 with a map of the percentage. And as you can see, just few states have 10 to 14% of obesity or BMI above 30. This is what happened in 2009. I'll go back. So definitely, obesity is here, and definitely we're going to have to deal with it. This is from the WHO, and again, speaking about obesity, and again, we are in the lead. So as everyone knows, there's a lot of studies, a lot of studies in the literature that have mentioned and proved that there's increased association of ventral hernias, postoperative complications from even doing hernia repairs in this patient population. There is at least 2 million abdominal surgeries done here in the US. This number definitely with the life expectancy is going to increase. It's estimated around maybe 150,000 or even more incisional hernias may happen. So the aim was just to look at the outcomes of the ventral hernia repair among the non-obese and the obese patients in our institution. After IRB approval, we did a retrospective study from 2002 till 2009. We divided the patients into two groups, a BMI of less than 35 and a BMI above 35. These are the parameters we looked at and assessed in our study. We used raw data gathered from the NSQIP, and all the patients had similar operative techniques, whether with the laparoscopic approach or the open approach, with the ultimate aim is to get an underlay of 3 to 5 centimeters using either a composite or biological mesh, depending on the situation, a combination of non-absorbable sutures and tacks. In the next few slides, the blue columns will represent patients with a BMI less than 35, and the orange one will represent the BMI greater than 35. In the group of BMI less than 35, we had a total of 539 patients, above 300 patients in the BMI greater than 35. Looking at the demographics, 47% females, versus 53% males in the BMI less than 35 and 70% versus 30% in the greater than 35. With regards to the age, the mean age was 55 in the BMI group less than 35, with a range from 22 to 85. And the mean age in the group greater than 35 was 50, with a range from 22 to 80. And that was significant. With regards to the BMI range, it ranged for the BMI less than 35 from 15 to 34, and for the BMI greater than 35 ranged from 35 to 73, with the average shown in the graph 28.1 versus 41.9. With regards to the OR time, and that's expressed here in minutes, average time was 64 for the BMI less than 35, and 123 minutes for a BMI greater than 35, and again, that was statistically significant. This is a graph showing also the demographics along the ASA classification, and the majority of the groups, as you can see, was ASA2 and ASA3. With regards to the wounds classification, again, the majority was class 1, clean wounds. Okay, with regards to the results, this is a graph shows the laparoscopic versus the open, initial versus recurrent across the board. Length of stay was 2 days versus 2.5 days for the other group. Here, the morbidity, 21.6% versus 11.9%, and the BMI in both groups. Mortality, very comparable, not statistically significant. This is the common complications across the board. The only statistically significant one was wound infection that was greater in the BMI greater than 35. This is the recurrence rate, 9.6% versus 14.9%, again, statistically significant. So operative time, length of stay, longer patient group of BMI greater than 35. Overall morbidities is again greater. However, across what's been mentioned in the literature, mortality and mesh infection has not been different, and recurrence length also is equivalent. More abdominal surgeries in the horizon, more incisional hernias will probably need to be done. Obesity epidemic is here, and I think more studies are needed for safer and better outcomes for this patient population. Thank you.
Thank you very much. We have 2 minutes for questions. Sir.
I may be asking too much,
Could
but
you tell us your name?
Oh,
and where
sorry,
you're from?
sorry. Rob Catani from Manchester, New Hampshire. I'd be happy to find anybody with a BMI less than 35 to operate on today. So, did you break out any more detail in terms of different BMIs greater than 35? Because you're really greater than 35 can be anything from your typical morbidly obese to a super morbidly obese, and I think those are different patients.
Yes, this is absolutely a very good question. We have a poster actually downstairs. We looked at our patient population. We had around 27 patients in the super obese with a BMI above 50, and they actually had very good comparable results. We did not have any mortality in it. Rate of mesh infection was very comparable. But in this study, in the presentation, I didn't include the divide, but definitely we looked at it. For sure, and I agree, yeah, definitely the super obese have definitely been also another category that we're looking at, even in the bariatric population in our bariatric surgery, in our group too.
Did you have the opportunity to look at different subgroups within this, like laparoscopic versus open, and if you could maybe shed light for us what you might have come across?
I hope this will be my next SAGES San Diego presentation. We definitely want, I'm really interested, as you said, to look in the laparoscopic groups in the same group, and again, look at other risk factors, probably like smoking or diabetes, other comorbidities, and correlate that with our complication rate, and again, the recurrence rate. Because looking at the literature, there is a wide array of results about the recurrence rate in open versus laparoscopic, but this is absolutely what our next step in our database, yes.
It would be fascinating.
Although your results in the patient groups were similar, did you compare any of the surgical challenges, the stress on the surgeon, the ergonomic inconveniences, or any of those kinds of things between the two patient groups?
Well, I think that would be good. I think we can do that, I guess, as a prospective trial, and I guess start including that. Unfortunately, this was just retrospective, but I think this is a very good point. Definitely operating, and the morbidly obese and angles, anchoring the meshes, especially if you're doing it laparoscopic or even open, definitely do perform or provide a challenge to the surgeons. Absolutely.
Thank you very much.
Thank you so much.